Okay, we're going to move into our next presentation, and we have one speaker for this one with us, Dr. Pat Parfrey, and Sister Elizabeth Davis will be joining us virtually via WebEx. Dr. Parfrey, I think you're starting.
I suspect a lot of you have heard part of our presentation, but we're trying to bring information together to bring stuff up to date. And in bringing it together, I don't think we're going to answer the question that was posed to us. How will Health Accord NL influence the province's economic trajectory? I'm not sure, but I'm going to provide a lot of information to allow us to see if we can predict. The first thing is that we are trying to create an accord between the people, the stakeholders, and the political system on what we should do with our health and social systems over the next 5 years with a hope to transform health within the next decade. So the plan will be a 5-year plan. And our key background fact is this. We need to face the facts about poverty and the economy. Poverty equals ill health. Poverty is very expensive. The economic cost of poverty is far greater than the fiscal costs, with 20% of the population marginalized. We spend big currently on the consequences of poverty, but not on the causes. Child poverty is unjust. Its economic and fiscal costs last a lifetime. And economic development is directly related to a healthy society. So that's the basic thesis on which we're building this presentation. And the next slide, and I'm going to discuss these pieces over the next 10 or 15 minutes, that there is a compelling case for change in health and social systems in this province. We have a health crisis. You see it every day discussed by not having enough family doctors. And we also have it by our health events. We've had very substantial demographic change, which I will go into a bit more detail than was presented earlier. There are substantial problems concerning the sustainability of the current model of healthcare. We have a fiscal crisis, depending on whether you're a left-winger or a right-winger. And we have climate change. And you would say, well, what are we interested in climate change for? Well, the reality is when we were in communication with groups in Labrador, that was the thing they brought up, being stuck in their communities for 4 days at a time with the septicemia. So what makes Canadians sick? And only 25% of it is about our healthcare system. The rest is about us and our social systems. So our vision has nothing to do with money. It's to improve health and health outcomes of Newfoundlanders and Labradorians through acceptance of and interventions in social determinants of health and a higher quality health system that balances community, hospital, and long-term care services. And it's the fact that we put those two thoughts in the same sentence that's really important to us. And our objective is to use evidence, strategies, and above all, intense public engagement to create this 10-year health accord that would improve health in the province and do so within the fiscal envelope of the province. So in the next, I pushed these, don't I? Yeah, sorry. So here's the information on life expectancy, i.e. if you were born in 1980, you would expect to live 1 year less than somebody born in Ontario. And if you go to the other end in 2018, look at the divergence. The difference between Newfoundland and Ontario is now 2.4 years. And where did that curve diverge? Oops. Oh, sorry. You can see that here it is going parallel and then it diverges. The next thing is we have the highest cancer mortality for men and women in the country. Canada's on the left, Newfoundland is on the right of this cancer mortality. That's age standardized. We're ranked 9th for cardiac mortality. We're ranked 8th to 9th for stroke mortality. Here's the monthly cost of homelessness per person in shelters in St. John's. Per month, $10,900 on hospital care. And that's only people in shelters. It's not people in other places that look after the homeless. So social circumstances matter enormously. We have the highest prevalence of food insecurity in the country in St. John's. Here you can see that 17% of families in that year had food insecurity. So what do we do about social spending in this province? Really nothing, really, in terms of we're flat since 1980. And Danny Williams mentioned the poverty reduction strategy, which I think was a very good thing, but really we're flat. Look at our health spending, and look where our health spending diverged. Parallel, social spending, health spending, boom, took off, 1994, 95. And I showed you life expectancy. Look on the other side. The divergence in life expectancy in this province occurred despite massive increases in health spending. These are slides Wade gave me. We were exposed to a massive demographic catastrophe in 1992, the cod moratorium. And we had a reduction in the population in the next decade of 7.8%, and in the following decade of 2.6%. And we just take it as, yeah, that happened. But what was the effect of that moratorium? The effect of it was that in the decade from 1990 to 2000, 57,000 people left the province, and they were all people under the age of 34. And they left from different places. They didn't affect the Avalon Peninsula. There was a reduction in population in Burin of 35%, Notre Dame Bay 34%, the South Coast of 41%, the Northern Peninsula 42%. The massive effects on those communities. And the impact of it has been that in the last 30 years, that the proportion of children in those places was reduced by 75%. That the number of children was reduced by 75%. And the proportion of seniors has gone up everywhere. And the Avalon has gone up by 107%. So why is the change so equally distributed? Because no young people left after the cod moratorium. All the older people stayed. And this got from Wade as well. Look what happened. Mortality, death rate. Here it is, between 500 and 600, going along quite nicely, and then it starts to take off. Goes above Canada here, and look where it is now. It's double what it was in 1990. So you had the increase in death rates, which is explained by a higher proportion of the population being elderly, but the increase in life expectancy is different, because the implications are that those young people that left were healthier than the people who stayed behind, and the people who stayed behind, who stayed here, were also left to absorb the social consequences of this cod moratorium. And by comparison, you see in Canada, there's no change in mortality at all and death rates over that period of time. Now, the next fact, I suppose, if you could call it that, on the top, we've got the ranking of the health system performances from the best, which is Australia in turquoise, down to the worst in the United States. And the closest to the United States is France and Canada. We're in the bottom tier of OECD nations for health system performance. And the reds are dots for the provinces. And we have the worst health system performance amongst the provinces, despite the biggest per capita spending. And we're actually an outlier in spending, like we are much bigger than everybody else. Now, the sustainability story, you know about the fact that we don't have, that 90,000 people can't access a family doctor, etc. Family doctors are in chaos inside and outside the cities. Here is the turnover rate of doctors in hospitals in Newfoundland from 2018 to 2021. And when you look at the smaller hospitals, they've either got new doctors or have vacancies as a proportion of the positions available, over 50%. And in Labrador Grenfell Health, it's even higher. And when you look at the proportions of people that have been in position for more than 3 years, outside for physician, the turnover rate, I mean, for family physicians, look how high they are. Outside of St. John's, rural, 76%. Out rural central, 71%. Outside Cornerbrook, 50%. Lab Grenfell, 115%. So this recruitment and retention is a crisis. And it's affecting hospitals and family physicians. So now, Sister, I'm going to hand over to you to tell people what are the solutions to these problems in our minds.
And Pat, you'll advance the slides as I ask you to.
Yes, Sister, I'll definitely do what I'm told.
It takes a while, but eventually you can train them. So we're in the midst of answering the question, what do we do about this? And when I say we're in the midst of doing it, we've been very methodical in our approach. We took our first few months simply to see where we needed to go. What are the directions we need to be taking? So in the first round of engagement with the public and many stakeholder groups, we asked that question. We didn't say, what do we need to do? We said, what direction do we need to take? They helped shape that direction for us. And we built then 6 strategy groups to begin to answer those questions. Then in our second round of engagement, we went back and asked, did we get the directions right? What else do we need to be about? In our third round of engagement, which happened at the end of June, we focused in some very specific areas, primarily on community teams and in hospital services, although we gave some inklings in the other areas. We will in October go back out again, now having more firm, possible calls to action, asking the public again, are we getting it right? And then in November, we will come back with what we think is close to the action, calls to action to complete that. So all the way along, we've been very conscientious, very thoughtful, very intentional about listening to the voice of the people, because it's the people's health, not my health or Pat's health. So we have a task force, we have 6 strategy committees, and we have 4 working groups. I'll allude to each of them as we move along. So at the big picture level, let me identify 8 broad pieces, if you will. The first, as you saw from the outcomes Pat spoke about in terms of life expectancy, in terms of chronic illness, and so on, we need to act on quite a number of social, economic, and environmental factors in this province. You heard the opening slide. Around poverty, we have tended to focus on consequences rather than causes. We need to change that. The second thing we know, and COVID throughout the country has highlighted this, is that we have not been careful, thoughtful in our care for older people. Pat gave you percentages of change in proportions of older people in this province. I want to give you another statistic. In the year 1971, we had 30,000 people over the age of 65. Today, 50 years later, we have 120,000 people over the age of 65. So care for older persons in this province is a significant issue and needs to be much better resourced, much more carefully integrated. The third area, which is really a basic pillar of what we're going to speak to you about and to the public and to the health accord itself, is around new community teams. I will come back to that. We also have 23 health centers in this province, well situated, well distributed. We have to reimagine their care. We have a good ambulance system, but it's not good enough. So what do we need to do to enhance and strengthen that system? Our hospital system is built on the premise that we're mostly young and most of our illness is acute illness. That is not true anymore. We're mostly older and most of our illness is chronic illness. So how do we reimagine, rebalance our hospitals to respond to those needs? Pat mentioned some indicators of sustainability around physicians. You would be heartbroken by the number of vacancies in nursing positions around this province today. In St. John's, in long-term care today, there's a crisis around vacancies for nurses. So how do we build a system that is sustainable into the future? And the good news story is, how do we use better virtual technology in a province where digital technology is one of our strengths, our creativity and innovation in this area? How do we use that well to improve our health system, which in effect and links it to the social system? So let's take each of the strategy areas now. The first one is the social determinants of health. You can imagine that is so broad, so wide. And one of the challenges we have is very little evidence around which particular determinants of health have the greatest impact on our health in this province. We know globally what will: poverty, education, income, social stability, inclusion. We know these things. So what particularly affects our health in this province? We're doing some very good work in this area. We are looking at systemic racism. We have a myth about our province that we're very open, very welcoming, very hospitable, and that is true to some degree. But if you're an Indigenous person in this province, if you're an immigrant from Africa in this province, you wouldn't be quite so convinced of that sometimes. The second area clearly is around poverty reduction at many levels. We believe strongly in the need for universal basic income, for the reduction of poverty, but also for the reduction of stigma around poverty. We do know universally that one of the best things we can do to improve health in the long term is attend to the child in care, in education, in the developmental years. We know in this province we have high levels of housing insecurity. People who are homeless, or people who are in precarious housing. You heard Pat speak about food insecurity for St. John's, the largest city, and one would assume the wealthiest part of the province. Labrador, we heard the same stories about food insecurity. And as Pat said, we tend in this province to ignore the impact of the climate emergency unless we live in Labrador, where we're more affected immediately by this, but we will be affected, as the whole globe is, by the climate emergency. But we've had boil water orders in this province for a very long time. So these are some of the areas we are attending to. In terms of older people, like most societies in the developed world, we have an ageist society. We haven't attended well to making our communities age-friendly, and we really need to do that. We have to have age-friendly communities if we're going to have aging in place, as we all deserve. Once people become ill or frail, we do need better management of the care, whether it's in home support or home care, in personal care homes and long-term care facilities, or in hospitals. And we need integration across these areas. We also need to be more intentional about foreseeing end-of-life care for ourselves. We're not as thoughtful as most other provinces in that area. In the next slide, you will see the community teams, which I've said are really the pillar of much of our calls to action. We want to move from being a hospital-centric health system to being a community-centric health system. We have good primary care teams across the province. They're quite haphazard in where they are. We need every person in this province and every community in this province under the umbrella of a community team, to have the breadth of professionals you need in such a team. You could have a population of less than 6,000 or 7,000 for the catchment area. So we're imagining geographic catchment areas, probably 34, 35, cover the whole province. These teams would be what you would expect: family physicians, nurse practitioners, nurses, allied health professionals, social workers, elder care workers, mental health workers, and so on. They would not all necessarily live in the same location. They couldn't really to cover the geographic area, but they're very tightly connected by the virtual care network. They also will link with the social programs within at the coalface as well, and with the hundreds of community organizations that are out there who are also helping provide support for health. If there's one word we've heard over and over and over again, it's the word silos. And what community teams have the capacity to do is integrate better through the community. In the next slide, then, we look at the emergency services. We have, as I said, good emergency services, but not good enough. We need a 24-hour, fully integrated, province-wide system with both air and ground ambulance, and we need the addition of more acute care paramedics than we have today. We also believe we would benefit, given our geography particularly, from a virtual emergency room, which is supported by specialists in emergency care, doctors and nurse practitioners. And we have seen models of this work very, very well in other countries. And the goal of all emergency services is to get the person needing care to one of our 13 hospitals right across the province, all of which fortunately now have CT scanners. In the next slide, then, you see the health centers. As I said, there are 23 of them scattered well distributed around the province. They're very much closely connected with the community. We want to enhance the model of urgent care that they provide. And the service level they provide may or may not also include beds, depending how close they are or how far away they are from the nearest hospital. Many of them today have long-term care beds, and we like that because that makes it closer to the community. When we look to our community hospitals, maybe go back one slide. Oh, okay, sorry, no, go ahead. So we're looking at our community hospitals. We're looking at 3 levels of hospitals, each one related to the population it serves. So the first level is the community hospital level. And there's been some pushback about our language here, but we truly believe the community hospitals are the core because they're the link, direct link with the community and between the community and the regional and the tertiary level hospitals. So if a population is anywhere up to 40,000 persons, that you would have a community hospital. If you have a large, so in the province right now, we imagine 7 community hospitals, all in existence. We're not closing any hospitals. So they would be Burin, Clarenville, and Carbonear in the eastern region. In the western region, it would be Stephenville. And then in Labrador Grenfell, it's St. Anthony, Labrador City, and Happy Valley Goose Bay. We imagine 3 regional centers. One will be St. John's. Second one would be Central. It's one regional center, although there are 2 hospitals in that area, and they are working with us to work through how that will look. And then one regional center at Western Memorial in Corner Brook. Given we are only 520,000 people, we can only support one tertiary center, and that center would be in St. John's, but it would not be confined to the geography of St. John's. We see more and more outreach, which is already beginning to happen, but more of that extended through virtual care and extended out through visiting specialists. There are a number of criteria for looking at what goes into which of these hospitals. Obviously, the size of the population, the geography of the population, the group themselves who are in that population. Is it primarily older? Is it a good mix? And so on. But a very important element of this is the ability to recruit and retain health professionals. And there's a very grave concern, as I said, around sustainability. The next slide is on terms of quality. One of our concerns is that even if we rebuild the system properly, we reimagine it properly, we rebalance it properly, how do we ensure that it remains faithful to that vision and these goals? So we do believe we do need a statutory council created, which would assume the responsibility for that oversight. We need accountability structures as we have now, but we need them in both health and social services. And we need to change the culture. We have a resistance somewhat in health and social systems to be truly learning organizations. And given the changes in the society now, We actually have to be always on the leading edge of thinking, reimagining, repositioning. And finally, the next slide brings us to the digital technology. And there are two dimensions of this. The first dimension, as I've mentioned several times, is around virtual care. Now, we were defaulted into virtual care very often since COVID came in, but that virtual care was primarily the telephone, which even I, the dinosaur in the room, know is pretty much archaic. So we need better virtual care. We need virtual care which extends further. We have commitments from all our federal parties in this election to strengthen the broadband coverage in this country. We've been promised by 2026 it will be pretty much permeating the whole country, and the part that is not covered by proper broadband width is covered by satellite. We absolutely need that. It's a key foundational piece of this reimagining. But even with that, we have to acknowledge the relationship between the health professional and the person who's receiving care. The person who's receiving care has to be comfortable with the technology, with that medium, and has really got to be the one to say this is acceptable or not. The second dimension of the digital technology is the information systems. While the public at large probably thinks it works well in healthcare, in fact, information systems are quite siloed in healthcare. Community care information systems long-term care doesn't talk to hospital care, ambulance care doesn't talk digitally to hospital care. We have quite a number, even from a regional health authority to regional health authority, we don't have that kind of capacity. That's not acceptable. And it doesn't have to be, but it will come at a cost to change it. Supporting
You've got 3 minutes left, sister.
Supporting these 6 working groups, 6 strategy groups or 2 working groups, 2 sets of working groups. The first set of 2 are focused on getting ready the providers within these systems, health and social, as we reimagine them. And that group is looking at the mix and distribution. The second group is looking at how we actually educate professionals and workers in the health and social systems in a different way so that they see this broader connection between the health system and the social determinants of health. Obviously, their work is overlapping, particularly around recruitment and retention of health professional workers. And the next 2 groups, one is looking at interdependence. How do we link the provincial and federal government, particularly around financing some of this? How do we link Indigenous nations governments with the provincial government? How do we link municipalities? That interdependence piece is also part of the 4th working group, which is looking at governance. How do we make all of this happen? How do we change a culture which thinks health resides in the health system, thinks it has nothing to do with social systems, when actually it has way more to do with social systems than it has to do with the health system, which is only there when it fails. So my final slide answers part of the first question that we said we would answer. Pat said, we can't tell you how we will influence the economic trajectory of the province. We can tell you with certainty, health or lack of health will affect the financial trajectory of this province, the economic trajectory of this province. We know that. We know it from evidence all over the world. Whether the health accord will affect that depends on you and people like you. If everybody in this province doesn't take some leadership in this, we will not change our health. We'll keep these desperately poor health records we have. Highest stroke mortality, highest heart disease mortality, highest chronic illness, highest complexity of illness among young medical challenges among young children. All of these are unacceptable. We don't deserve them. We can't have them. But it won't change unless all of us take leadership inside government, inside public institutions, inside community organizations, inside the private sector. If this is not truly an accord with all of us engaged, all of us passionate about this, all of us committed to making it happen, we'll maintain very, very low health status, high health inequity, and we will never become economically healthy as a province. Thank you.
Slade, and I'd like to ask a question about everybody having a family doctor. Is that realistic in Newfoundland if one looks around rural Newfoundland? I came from rural Newfoundland. Our family never had a family doctor. And I don't think it's really practical to think that, you know, in everybody would have a family doctor. If you live in the bottom of Placentia Bay, everybody goes to Clarenville to see a doctor. But I don't think there's not enough doctors going to be in Clarenville to serve, you know, a couple of hundred people in North Harbour or Garden Cove or wherever. So as a question about that, is that a realistic thing to think everybody should have a family physician? Secondly,
One at a time, Gordon. We're nearly your age.
I'll just do just a quick one. What is the problem with nurses? Is that there are not enough young people who want to go nursing? What's the problem there? Thank you.
I'll answer the first question, and Sister can answer the second question. So the whole idea of these community teams is around this access issue. So if you think of the South Coast, the Canadian Peninsula, there's 7,000 people exactly in that peninsula. They have 3 or 4 doctors in Harbour Breton. They've got a nurse practitioner in St. Albans. They've got paramedics down the coast. They've got some allied health professionals in other places. So the whole idea we have is that they're all connected, and that the 7,000 people are connected to that team, so that the doctors that are in Harbour Breton would be following a blended capitation model, and they would deal with the medical questions, and the other people would deal with the things that they're expert in. So we're hoping that doctors are no longer doing stuff that they do to get a fee that's really not necessary, like renewing prescriptions or those types of things. So if you imagine that those people that are currently there are connected virtually, and they're able to provide different skill sets to the 7,000 people who are connected to them, we feel that access is feasible. We think that this proposal is the glue that will hold the medical system together. And if it doesn't work, we're in trouble. So, Sister, you answer the nurses.
In terms of the nursing question, there's never a simple answer to a complex question like that, because it's not too much different from why can't we keep physicians either. But I do believe that it has to do with healthy workplaces. And right now, very often within the health system itself or in the social systems themselves, the places are not healthy to work because people are stressed. The system is somewhat in a situation where we don't have much control over the working environment. And as long as that exists, we're not going to be able to provide the kind of integrated care that we need. We do believe, and nurses have said it to us, physicians have said it to us, allied health professionals have said it to us, if we have better working environments, if people are more integrated in their approaches, if they feel more support from each other, we will see an uptake in people willing to go into the professions, number one, and people actually educated in Newfoundland willing to stay in Newfoundland and Labrador. So we believe that healthy workplaces which allow healthy workers to continue to work are at the core of your question, Mr. Slade. We really do believe that until that's changed somehow, and that can't be changed by the flick of a switch. That can't be changed next Tuesday morning with some magic bullet. This requires this thoughtful approach that we're taking and thinking we're taking of rebalancing the system so it's a healthier work environment as well as a better system for all of us to be supported by. But the healthy work environment is key here.
Okay, we'll take another question. Over.
Are you ahead of me?
No, you're ahead.
Okay. Doug May, Munnell. First of all, Pat, Dr. Pat, kudo. And Sister, I really like the fact that in your framework you've concentrated on outcomes rather than just dollars. The fact that you're looking at what are these outcomes, and the fact that you talk about some of the worst outcomes, I think correctly, in the country, but with the most dollars spent. So just balancing the budget won't do it, because you have to think about the outcomes. Going back to the framework, though, I have a question on what it includes. For example, that when you look at the determinants of health, the population health model, then you seem to be in the area of prevention, if we could eliminate poverty. But in fact, a lot of your framework seems to be on health care. But there seems to be a connection, at least in my mind, between prevention and care. You know, like if you spent your money on prevention and people didn't need care. So how, in the wider sense, do we deal with prevention? For instance, chocolate milk or chips at school, or this professor who's led a very sedentary life. How do you deal with that? How does that prevention fit into your model?
Well, I think that it's at the core of the model, that this whole idea that we have to act on the social determinants of health is at the core. And the reason that we're emphasizing the fact that our social spending has been flat for 38 years, as against our medical spending going up by 232%, is just illogical. So what we're trying to do is to say, if we want to improve health in this province, we have to have a holistic approach. And a holistic approach involves the social system, it involves the prevention, and it involves the management. So that's really kind of the big message, that it's holistic. And then the second major thing is that it has to be integrated. So the idea is that the social system and the benefits that might accrue from more attendance to social factors needs to be integrated into the community side and into these community teams that are going to provide both social intervention and medical intervention, and they have to be linked to the community hospitals. And then so that we're really stressing in a big way, everything across the gamut has got to be more integrated. We're experts at silos in this province, and silos don't benefit patients. They only benefit providers. Sister, do you want to add to that?
And Dr. May, you were talking, the examples you used are all around health literacy for people like you and me who are well off, who have good food, who have warm homes. When you look at population health itself, though, there's a deeper level we need to move to. And there are societal, systemic issues in our society that keep us from being healthy. And the changes in lifestyle that I might make will have some impact on my personal health. But when you look at the population health lens, it's a much deeper lens than that. And that's where we are focusing. The challenge we have, it's just such a big thing. Like, we could be tempted to say we need to change the world. And obviously that's going to get us nowhere, because it simply will mean everybody will nod and agree we shouldn't have poverty, we shouldn't be exclusive, we shouldn't have people, young mothers living in the poorest, who are single parents living in poorest neighborhoods. We shouldn't have any of that. We nod and agree and do nothing about it. And we have evidence of that. As Pat said, our social spending has been flat for the past 40 years. Our health spending has increased over 230%. So in our minds, we believe the health system has everything to do with health. So how do we change that culture? Teaching you and me to have better health practices is not how we're going to do that. That's important. It's nowhere near the bigger picture. And the greatest challenge we're going to have, and you put your finger right on it, is how do we convince our government, the provincial government as well as municipal governments, how do we convince owners of businesses, how do we convince the people at Memorial and College of the North Atlantic, how do we convince all of us that we need to look at those deeper social issues, these flaws in our society that keep us so unhealthy? And how we do that, I'd appeal to you to help us find a way to do that. We talk to some of the best people in Canada who are working on social determinants of health for decades. And they tell us that they are personally frustrated. They keep at it, they keep passionate about it, but they say, don't be surprised if all you get are nods and absolutely no action. So that's something any of you're quite a broad base in this group today. If any of you have resources or ideas or know places that have managed to do this, we'd welcome that kind of input from you.
And I'd just like to add, we deliberately not deliberately, we began to understand the COD moratorium effect bit by bit through help with information that Wade gave us. And I don't think that we perceive that the COD moratorium had such major regional effects from a demographic perspective, but that they were linked to life expectancy. So if we went deeper into the regional effects in life expectancy, I'm sure they will occur in those areas that have been most influenced by the COD moratorium. And what do? Like as a governance system, we had flat social spending, and put up medical spending on it wasn't in response to the COD moratorium, but at the same time, it went up massively and had no effect.
And made no difference.
Thank you. We'll move on with our next presentation. So thank you, Dr. Parfrey and Sister Davis. Next we have Dr. Ryan. Thank you. Next we